welcome back. Today we will learn about Tetralogy of Fallot, that is TOF. Okay, so Tetralogy of Fallot is a cyanotic heart disease. Here cyanosis will be present and this will be a right to left shunt. Okay, so going to the definition of this, it's a cyanotic heart disease and it is more common in males. Okay, whereas in case of ASD as well as PDA, we had learned that the incidence was more common in females than males, but here this Tetralogy of Fallot is more common in males. Okay, and what is the pathophysiology of this Tetralogy of Fallot? Let me draw a simple diagram now. And you know that there are four important components of Tetralogy of Fallot, that is pulmonary stenosis, then right ventricular hypertrophy, VSD, ventricular septal defect, and one more thing is overriding of aorta. And I will try to simplify this pathophysiology as much as I can. Okay, so imagine there is a heart, we have four chambers, and from the left ventricle aorta arises. From here aorta should arise. Okay, and from here you have the pulmonary trunk, that is pulmonary trunk, and it divides into pulmonary arteries above. Okay, now this is the simplified diagram, you know that. Suppose imagine during intrauterine life some abnormality occurs and that leads to anterior deviation of pulmonary trunk. What do you mean by this? This pulmonary trunk you can see here, right? And this is the pulmonary valve which will differentiate the right ventricle from the pulmonary trunk. Okay, so this pulmonary trunk gets little bit anteriorly deviated, that causes obstruction or stenosis of the pulmonary valve. And one more thing, you may learn about subpulmonic stenosis, that indicates the stenosis will be little proximal to the pulmonary valve. Okay, it will be little proximal to that, either subpulmonic valve stenosis or the pulmonary valve stenosis. This both can occur in TOF. Okay, now what happens? As there is obstruction here, let me draw in a black color this stenosis or the obstruction. So you have this stenosis here. Okay, so what happens? The blood is not able to flow from the right ventricle to the pulmonary trunk. So the blood will come to the right atrium, then to the right ventricle, and from here the blood is not able to pass through the pulmonary trunk as there is an obstruction present there. So what happens? Eventually right ventricular hypertrophy occurs. So right ventricular hypertrophy, RVH, right ventricular hypertrophy had occurred. Now as you can see here, the blood is nowhere to go. In case of ASD and VSD there was a shunt present between them, but here there is no shunt or no pathway for the blood to go. So the nature tries to compensate this abnormality by providing another abnormality, that is high VSD, that is ventricular septal defect, which occurs at a relatively higher position in the membranous septum. You know that membranous septum is above and the muscular septum is below. So there will be a presence of membranous VSD in case of TOF. You can see here, this is the gap, potential gap of ventricular septal defect. So the blood in the right ventricle can get shunted towards this gap into the left ventricle. Got it? So what happens here? Right ventricular hypertrophy developed and that pushes the blood from the right ventricle into the left ventricle through this high VSD. Okay, this is the right to left shunt and is called as cyanotic heart disease because it is bypassing the lungs. The blood is not going to the lungs and this whole amount of deoxygenated blood is pumped directly into the left ventricle. Okay, that causes cyanotic heart disease. And now this huge amount of blood which is residing in the left ventricle, that will try to pass through the aorta. So if this huge amount of blood is passing through this aorta, it will lead to dilation of the aorta, and finally it leads to overriding of aorta over the interventricular septum. Okay, first what happens? There will be a pulmonary stenosis, then which in turn causes back pressure in the right ventricle, causing right ventricular hypertrophy. And what happens? The nature tries to compensate this abnormality by providing another abnormality so that the blood can get transferred from one ventricle to the another ventricle, that is high VSD. By this, the deoxygenated blood in the right ventricle will be pumped directly into the left ventricle. As this huge amount of blood is directly passing through the aorta, it causes dilatation of the aorta, leading to the displacement, causing overriding of aorta. Got it? This is the simple pathophysiological mechanism, and this whole amount of deoxygenated blood will be circulating throughout the body, causing cyanosis. So cyanosis is a characteristic feature of Tetralogy of Fallot. Got it? Okay, so let me learn this. Pathophysiology, I had said you before, this is due to anterior deviation of subpulmonic tract, or you can say it as the pulmonary trunk. Another is right ventricular outflow tract. These words are used synonymously. Okay, you can use right ventricular outflow tract, or you can use subpulmonic tract. It depends on your choice. Okay, and then there are 4 components. You know how these 4 components develop, I had said you in detail, right? So you have the subpulmonic stenosis or pulmonary infundibular stenosis. That is, pulmonary infundibular stenosis denotes the stenosis which occurs little proximal to the pulmonary valve. Okay, now and then right ventricular hypertrophy occurs, high VSD develops due to the nature's compensation, you can say it like that, and finally overriding of aorta occurs due to displacement. Okay, coming to the compensatory mechanisms in the body. So as the child develops this tetralogy of Fallot, he will experience severe cyanosis. The body tries to compensate for this in the form of 3 mechanisms. First is polycythemia. You can see here polycythemia, the cyanosis will stimulate the bone marrow to produce more amount of RBC. So erythropoietin will be released from the kidney that will stimulate the bone marrow to produce more amount of RBCs. But remember, the oxygen saturation in the blood is decreased here. There is no problem with the RBC. So even though this is considered as a compensatory mechanism by the body, but actually it does not compensate. Instead, it aggravates the cyanosis. Okay, so you can see here more amount of RBCs are produced, less oxygen is available for saturation or for binding with the hemoglobin, so amount of reduced hemoglobin is formed, right? If the reduced hemoglobin is greater than 5 grams per deciliter, it is called as cyanosis. So obviously more amount of reduced hemoglobin will aggravate cyanosis. Okay, and the second one is formation of collaterals between aorta and pulmonary arteries. So this is the actually real compensatory mechanism. If the collaterals between the aorta and the pulmonary arteries are developing, then the deoxygenated blood which is reaching the aorta, that will get diverted to the pulmonary arteries. And if those blood gets diverted to the pulmonary arteries, then they can get oxygenated and the patient may get relieved of his or her symptoms. Okay, so this is a real compensatory mechanism. And the next one is the persistent PDA. Remember, patent ductus arteriosus, if it becomes persistent in case of TOF, it is an added advantage. How? The same mechanism. The deoxygenated blood which is reaching the aorta can get diverted to the pulmonary artery through this patent ductus arteriosus, and the blood can get oxygenated easily. Okay, so it is an added advantage in the face of tetralogy of Fallot. So the real 2 compensatory mechanisms which the body tries to compensate are persistent PDA and formation of collaterals, whereas the polycythemia, which is generally considered as compensatory mechanism by the body, but actually it does not compensate, instead it aggravates the cyanosis. Okay, next coming to the hemodynamics. It's a simple thing. Let me draw the diagram here only. Suppose you have this heart, right? So here you have this stenosis in the pulmonary trunk and you have the VSD here, high VSD. Obviously the deoxygenated blood will enter here, right atrium, from right atrium to the right ventricle, then through the right ventricle, as it is not able to pass through the pulmonary trunk, it will directly get shifted or shunted towards the left ventricle. From the left ventricle, this huge amount of blood will pass through the aorta and it will circulate throughout the body. So in short, deoxygenated blood is circulating through the body causing cyanosis. Okay, the same thing is repeated here. Deoxygenated blood from the right ventricle diverted to the left ventricle and it reaches the systemic circulation, and very little amount will reach the pulmonary artery, even though it is little bit insignificant here. Okay, the little amount of blood which is reaching the lungs may get oxygenated, but the amount of deoxygenated blood is higher when compared with this oxygenated blood. Final consequence will be development of cyanosis only. Okay, now what is this acyanotic Fallot? Remember, generally Tetralogy of Fallot is a cyanotic heart disease, but there is some condition where it can become acyanotic. How? Let me justify this. Suppose the stenosis is submaximal or minimal. The stenosis is minimal, and so what happens? The amount of blood reaching the pulmonary artery is more. Suppose consider this as the heart and you have this pulmonary trunk. Subpulmonic stenosis is minimal. That means it is not stenosed to a maximum extent. The stenosis is minimum. Okay, so the blood which is coming into the right ventricle, they will be able to pass through this pulmonary artery and get oxygenated in the lungs. So the patient will be devoid of cyanosis. the symptom cyanosis will not be present in this case, as the stenosis is minimal and the blood can easily flow through this pulmonary artery and get oxygenated in the lungs. Okay, so this is called as acyanotic fallot. There is obstruction to the pulmonary artery is less, that means the stenosis is minimal, so more amount of blood can reach the pulmonary artery and gets oxygenated, so cyanosis will not occur, and the patient is also called as, this condition is also called as pink fallot. And now coming to the clinical features. In clinical features, obviously there will be central cyanosis, which is a characteristic feature here, and clubbing will be there, dizziness as the oxygen is not reaching the brain, that leads to dizziness, syncope, and it will stimulate the neurons in the medulla and the pons and causes hyperventilation leading to dyspnea, difficulty in breathing. Okay. Now this is an important concept here. What is hypercyanotic spell, cyanotic spell, hypoxic spell or the tet spell? 4 names equal the same thing. Okay. Imagine a child who is having tetralogy of Fallot. Okay. Now what he does is, due to some reason, he is developing systemic vasodilation. Like in case of exercise, if he is playing a lot, okay, if he is playing a lot, or if he develops fever, in this exercise and fever, what happens? Usually there will be systemic vasodilation, and when this vasodilation occurs, what happens to systemic vascular resistance, whether it increases or decreases? Obviously the resistance to blood flow decreases due to vasodilation, so there will be decrease in the systemic vascular resistance. This is important point here. Okay. Now this causes, as the SVR pressure decreases, the pressure in the aorta also decreases, because this systemic vascular resistance indirectly depicts the pressure in the aorta, right? So the pressure in the aorta also decreases. If aorta pressure decreases, then it will try to suck more amount of blood from the right ventricle through the VSD shunt, right? So the shunting of blood from the right ventricle to the left ventricle will be increased a lot, and the cyanosis will aggravate. Now this aggravation of cyanosis will stimulate, it will further stimulate ventilation, right? So ventilation is stimulated. As the ventilation gets stimulated, the intrathoracic pressure decreases and more amount of venous return occurs, right? Venous return is increased, and this venous return will lead to more shunting of blood towards the left side, obviously. So the cyanosis will get aggravated even more. This is called as hypercyanotic spell. Okay, let us have a short recap here. The patient, a child who is doing a lot of exercise by playing or crying, or if he is suffering from fever, that can lead to vasodilation, and this vasodilation will cause the pressure in the aorta to get decreased. Systemic vascular resistance decreases, and it sucks more amount of blood from the right ventricle, causing the cyanosis. That is, cyanosis aggravates in this condition, and also this aggravation in cyanosis will stimulate the respiratory centers in the brain to cause hyperventilation. So the child will go into a state of hyperpnea, which will in turn cause increase in venous return, and the shunt flow further increases, causing the hypercyanotic spell. This is the pathophysiology of hypercyanotic spell, how it develops. Okay, and what is the mechanism to relieve this hypercyanotic spell, or what is the posture which is adapted by the child to get relieved of this symptom? That is squatting. Yes, obviously when the child tries to squat down, femoral artery gets compressed, right? The femoral artery gets compressed, femoral artery compression. When the femoral artery compression occurs, the systemic vascular resistance increases. It increases. Systemic vascular resistance increases. When this increases, the pressure in the aorta also obviously increases, and this increase in pressure of aorta will not suck the blood from the right ventricle. That means the shunting of the blood from the right ventricle to the left ventricle will be decreased. Got it? This is the mechanism by which the child tries to get rid of hypercyanotic spell with the help of squatting technique. Okay, so the child prefers a squatting position so that the systemic vascular resistance increases due to the compression of femoral artery, and this causes the pressure in the aorta to get increased, which will decrease the shunt, shunting of the blood. Okay, slight touch up on the investigation and treatment part. Here in X-ray you will see a boot shaped heart, and how this boot shaped heart is formed, that mostly you will learn in medicine. Here we need not to deal with it, okay. And coming to the treatment part, knee chest position, that is the squatting position, help the child to get rid of this symptom, hypercyanotic spell especially, and oxygen supply should be given to reduce the cyanosis, and morphine will reduce the hyperventilation, it will depress the respiratory centers in the brain so that hyperventilation can be turned off. Then the vicious cycle of hypercyanotic spell, where hyperventilation acts as one of the factors for causing increased cyanosis, will be eliminated, okay. And finally sodium bicarbonate you can give for treating acidosis. Okay, you no need to have that much knowledge about this treatment as well as investigation part, you can learn it in medicine. Here I want you to know about pathophysiology in detail, okay, as well as hypercyanotic spell, how it develops and what is the mechanism adopted by the child, or what is the posture adopted by the child to get rid of this hypercyanotic spell, okay. So that we had concluded our session of Tetralogy of Fallot. Hope it was useful for you. Thanks a lot.